Thank you. My Lady, I speak on behalf of the National Care Forum. My Lady, in our opening statement for Module 6 of this inquiry, we asserted that social care was overlooked, misunderstood and disadvantaged in a variety of ways, which worsened the impact of the pandemic on recipients of care and support, their communities, care workers and care and support providers. The evidence we have heard and read over the past month shows that the situation was significantly bleaker than we expressed. My Lady, you and your team have been painstaking in your analysis of the situations facing the sector. You have heard from officials and government ministers that this was a sector that was underfunded, fragmented and diverse, and the responsibility of 150 plus different authorities. You have heard that care was delivered by a patchwork of local authority, not-for-profits, small and very large private organisations. That social care is complex, delivering home care, residential care, day services, supported living, extra care housing and more for all ages. You've heard from a Secretary of State who felt they had limited levers over the sector and a care minister who evidence indicated her views were overlooked and on occasions overruled, and that there was no real-time data to understand what was happening on the ground. These things are, of course, part of the picture. However, I hope that you have also heard that despite these factors, that social care is staffed by extraordinary people who during the pandemic worked as hard as they could to keep people safe. You have heard directly from witnesses who gave painful and vivid testimony of the reality of working in a care home during the pandemic, of people working in the community who overcame enormous logistical barriers to access the testing and PPE to continue to deliver. You have heard about organisations, the majority of which were very small, who turned themselves inside out to cope with unwieldy, often contradictory, interrelated guidance that did not recognise their operating environment, and organisations who completely repurposed their accommodation to enable visitors within extraordinarily restrictive guidelines, and staff and organisations who took on health tasks when community health services stopped coming. They all did this against a backdrop where social care, the people it supports and carers, both paid and unpaid, were not prioritised, and this must never happen again. We heard from some witnesses that all the solutions for social care come under the umbrella of reform, and that task has already been assigned to Baroness Casey. However, whilst we urgently need her focus on social care, what you've heard during this module are not the longer-term ambitions of reform. These are the basic necessities of getting social care to be ready for another pandemic. These are not things that can wait. They are urgent. They need gripping and they need action now. There are two strong themes that I want to emphasise in this closing statement, alongside a reflection on many of the recommendations that the inquiry has heard. These two areas relate to the status of social care and its role as a public service. Multiple testimony during this module has focused on the inappropriate lower status attributed to social care in decision-making, resourcing, political focus and prioritisation. Powerful testimony from care providers, local government colleagues, directors of social services and others are clear that there were multiple occasions where social care was not recognised for the work that it was doing or for the expertise that was held by those fundamental to its delivery. Questions asked by the inquiry have demonstrated starkly the lack of ownership and accountability exhibited by public bodies, both in where they thought responsibility sat and the siloed approach to developing responses to the challenges facing the sector. Responsibility at the local level swung between NHS England and local authorities, and almost always the needs of the acute hospital system trumped those of people living and working in care and support. Even at ministerial level, accountability was unclear and confused, with huge delegation of tasks by the Secretary of State, but seemingly without the associated power, oftentimes leaving the Minister frustrated at the system's disregard of many of her concerns. It has been very important that the inquiry has gathered evidence in relation to the months before the pandemic began in the UK. During these precious missed months of January and February 2020, organisations like the National Care Forum were raising questions and challenging the unworkable nature of advice being put forward by experts without detailed understanding of social care. While ministers and officials were behind the scenes discussing the presence of asymptomatic transmission, guidance was dispatched that was impossible to implement and created a false sense of assurance about the risks. During this precious pre-pandemic period, there was no attempt to have a strategic conversation and build a formal partnership with social care, meaning there were multiple missed opportunities to work through the potential implications and the respective mitigations for those receiving care and the care workforce. The failure to include adult social care meaningfully in pandemic planning must never be repeated. Adult social care and support providers and their representatives must be included as core strategic partners in pandemic planning exercises, expert advisory forums such as SAGE, decision-making groups, relevant task forces and policy development. Representatives from adult social care should also be included in governance arrangements at a local, regional and central level to ensure their perspectives and operational realities are fully considered. Not recognising the importance of social care resulted in guidance that was nigh on impossible to implement, unsuitable to the settings and the people it applied to, with implementation timescales that were far too tight. This point was made very powerfully when one witness described the impact of the guidance developed in relation to visiting, where the lack of understanding of the needs of those receiving care and support meant that the guidance was so potentially damaging that people needed protection from the measures included in the guidance that had ostensibly been brought in to protect people. I am of no doubt, my lady, that you will have understood just what an integral role social care plays in the lives of millions of people. It is clear to us that social care is a vital public service in its own right. However, at the outset of the pandemic, social care was seen as a tool to enable the acute health system to continue functioning. It was noted by the former care minister in her oral evidence, it's almost as if what matters is hospitals and not the health of the whole population. And she went on to ask, what would it take for the NHS leadership to be thinking about the health of the whole population, including those who receive social care? It seemed that the system could see people when they were patients. It understood they needed tests. It understood that those who worked with them needed PPE. It understood they needed access to clinicians to address their wider health needs. Yet it seemed to lose sight of those self-same people the minute they stepped out of the hospital door. This is not a new feeling for those receiving care, but it must change. In reality, the public service that is social care is in fact often much more fundamental and embedded in people's lives than that of the health sector. It is often providing them with a home, support to access jobs, education, ensuring they have a positive end of life, supporting their connection with families and friends, enabling them to rebuild and reconnect in a million different ways for a million different people. It is delivered through long-term relationships with an extraordinary workforce who are as diverse in make-up, skills, experience as the needs of the people receiving care. It has been suggested by a witness in this inquiry that it is unhelpful to pit public services such as health and care against each other. However, I would politely suggest to that witness that the evidence heard during this module would suggest that any amount of pitting that the inquiry may or may not choose to do, it will find its starting point is fundamental and entrenched dominance by health, the reality of which had devastating consequences for the social care sector and everyone connected with it. This embedded disregard for social care has sustained beyond the pandemic, and it has been alarming to hear from a number of witnesses who spoke of the dismantling of key measures introduced during the pandemic to support adult social care around data and research innovations. It is not good enough for these to have been crisis-based responses, and dismantling them hamstrings future efforts for academic research, reform, integration with health services, and the ability to respond to early warning signs. My lady, during this course of this module, there have been a large number of recommendations that we would like to offer our support to. In our written submission, we will provide more detailed feedback around the practical implementation of these. However, for the purposes of this statement, these include, but are not limited to, in relation to the workforce, the development of a register of workers and the provision of step-up training to be made available for social care staff in line with new responsibilities and skills required during a pandemic. In relation to IPC, peacetime preparation of key building blocks in IPC, such as fit testing, measures to ensure immediate access to the PPE supply chain and the free supply of PPE in the advent of the pandemic, and the establishment of protocols and understanding of how to prioritise testing and vaccination for all parts of the care sector, to be delivered in situ where possible. Funding during a pandemic, the ability to get funding directly to providers at pace and without bureaucracy, and the instigation of payment mechanisms such as pay on plan that ensure that delivery decisions are not predicated on financial imperatives. For essential carers, the need to ensure that families and essential caregivers are still able to see their loved ones, and that effective IPC measures are in place to enable this safely. And finally, around data and digital, to rebuild and sustain the architecture for real-time data to enable early warning signs in relation to the impact of any future pandemic. The development of a social care data observatory and a commitment to strengthen the digital framework and expertise. My lady, in conclusion, it is clear that the people who work in, draw upon and provide care and support services were simply not prioritised by decision makers whose focus was on protecting the acute health system rather than citizens in all communities. Before I close, I want to pay tribute to the amazing work of our not-for-profit members and their care and support workers. They provide an essential public service and enable people of all ages and all circumstances to live good lives alongside the communities and people they love. The care they provide is the backbone of many communities, families and local economies, as well as the wider well-being and population health. We forget that at our peril. My lady, my final words are to recognise the strength of those witnesses who provided powerful personal testimony to the inquiry. I have been very impacted by their words, and one phrase spoken epitomised what I have heard throughout. We all deserve better. Those are our closing submissions, my lady.
Thank you very much indeed, Professor Rayner.